Hello everyone, we are pleased to make a presentation for the Lesson 2 of the section of Korean Journal of Radiology. Our study is about the MRI findings in trigeminal neuralgia without neurovascular compression and the implications of the Petrous ridge and the trigeminal nerve angles. Now we hope to introduce our key results briefly. Highlights include 3 points. We aim at the anatomical characteristics of trigeminal neuralgia without neurovascular compression. We found the angle of the Petrous ridge and the angle of the trigeminal nerve was significantly smaller in such a specific population, and we thought APR and ATN were capable to provide additional information on diagnosis. First, we would like to introduce the study's purpose and background. As we put before, we intended to depict the anatomical characteristics of the Petrous ridge and the trigeminal nerve in TN without MVC. MVC is considered the main pathogenesis of TN, but there are some occasions it cannot explain completely. For example, some post-microvascular decompression imaging cannot find a recurrent MVC for those recurrent TN patients. MVC might not be found occasionally during surgical explorations, and negative findings varied from 3% to 89% in former studies. And even in healthy and normal population, MVC could be recognized as well. Therefore, some studies were centering on exploring other substantial causes of TN. Some researchers paid attention to the trigeminal nerve and its surrounding tissues and structures. They tricked them to identify likely locations of mechanical compression, and some anatomical studies found nerve branches may be tensioned and compressed by spurs or ossified ligaments near bony foramen ridges. Besides, some surgical methods made the trigeminal nerve straight and flaccid, such as the arachnoidal dissection, and showed good efficacy. A former imaging study also reported the Petrous ridge might contribute to TN. And all of this brings our attention to the Petrous bone, which was expected to be an underlying factor resulting in the angulation and compression of the trigeminal nerve. Based on the former study, we consider if vessel interference were ruled out, that is, we selected these TN patients without MVC, the impact of the Petrous bone on TN could be explored more directly. Therefore, we aim to capture the anatomical characteristics and determine their diagnostic performance. According to the International Classification of Headache Disorders, we enrolled patients with classic TN between May 2017 to March 2021. MRI images mainly contain high-resolution 3-dimensional T2 sequences. Through post-processing, we measured 2 key anatomical values, and we performed statistical comparison and ROC analysis. Figure A and B shows the main methodology. Axial images are centered on the cisternoid segment of the trigeminal nerve, as a yellow line shows. The oblique sagittal view of the measurements on each side is following the axis of the cisternoid segment of the trigeminal nerve, as the blue line shows. The angles of the Petrous ridge and trigeminal nerve are hourglass. Black arrows indicate the course from the cisternoid segment of trigeminal nerve to the ventral pons. MC indicates the area of a Meckel's cave. As figure C and D show, the angle of the Petrous ridge is measured following the upper ridge of the Petrous bone in a patient under control. As figure E and F show, the angle of the trigeminal nerve is measured following the path from the Meckel's cave to the upper Petrous ridge and from the upper Petrous ridge to the pons in a patient under control. In our study, 66 patients with unilateral TN and 57 controls were included. Patients and controls show no differences in sex or age, as Table 1 summarized, and detailed effective side were listed as well. We compared APR and ATN between the symptomatic side, we, the asymptomatic side. Besides, APR and ATN on the symptomatic side were compared with the controls as well. We found APR and ATN showed significant differences between symptomatic and asymptomatic sides in patients, and also different between the symptomatic side of patients and controls. That is, APR and ATN were smaller in patients and on the symptomatic side. Next, we performed the LOC analysis of the Petrous ridge and trigeminal nerve angles for diagnosing. LOC curves are shown. The points yielding the highest yielding index value are marked. Accordingly, AUC, sensitivity, and specificity were obtained. These findings may provide additional information for the diagnosis of TN without MVC. In conclusion, we found APR and ATN were smaller, which might be a potential cause of TN without MVC, and this parameter might be useful for predicting and evaluating these patients. At present, MRI is used in routine for TN patients, and the three-dimensional reconstruction and measurements could become a part of clinical practice. Assessments of Petrous ridge and trigeminal nerve could help in predicting and evaluating TN patients without MVC, and we think the anatomical characteristics around the porous trigeminal nerve deserve more attention during surgical exploration and in future research. Finally, we sincerely appreciate this opportunity to share and promote our research. Thank you all for watching.